All right, so I was telling the other presenters that I kind of picked this topic because it's not an area of strength for me, and I wanted to read a little bit more about it. I feel like, again, when I took over the clerkship, my first goal was to try to get students interested in emergency medicine. Like we get some kind of kickback the more students go into EM. And since that time, I've really been able to kind of dig into some of these issues. We've also had an LCME site visit in the time that I was the clerkship director, which if you haven't gone through that, it's a stressful, agonizing, but really great way to learn medical education. I mean, if you can participate in an LCME visit, you'll learn what medical schools do. So some of these slides are going to be text heavy. And part of that is I want you to have these as a reference, and you can review the LCME standards on the learning environment. So this is one of those things where, again, your medical students will ask you why you keep asking them questions about intimidation and ridicule. And you have to explain to them we're asking these because the LCME requires that we track these things. So a couple of the standards, so LCME Standard 3 is academic and learning environments, and it requires that a medical school ensures that the program is professional and respectful of the students, and it recognizes diversity and promotes the students' success as physicians. The first LCME, the first two standards say that residents should participate in medical school education. So one of the ways that we help with that is when our new interns arrive on campus, we have a 2-day kind of resident boot camp. I don't even know what it's called, but the folks in the medical school are tasked with teaching the residents different things. So we teach them learning environment, we teach them the 1-minute preceptor, we teach them Title IX issues, all those things, and make sure that they know. We realize not every new resident or fellow is going to be like Teacher of the Year, but there are some things that your residents need to know for the LCME. The other thing that you're required to do is have medical students be able to participate in scholarly activities and research. So that's another standard there. So what is the learning environment? The learning environment is everything that goes into where the student learns. And the learning climate is how students experience or perceive the learning environment. And part of this is important, and we were actually talking about this before. Like, it's very hard to teach medical students in the environment with which we work, right? Constant interruptions, high stress, people yell at us, they spit at us, they throw punches, we have to chemically restrain them. No other place do you get called names. Like, I wouldn't go into McDonald's and start dropping F-bombs on the person working, but that happens to us all the time, right? And so maintaining that professionalism, one of the things that I've found, too, just as I reflect on this, is a lot of the reports that students, when they report faculty for intimidation and ridicule, oftentimes it isn't directed towards the student. It's an episode where they witness the attending belittling a nurse or what they perceive as belittling a nurse. Have you run into that at your institution? I would say that, it's the student was very respectfully handled, but the attending berated the nurse in front of the student. That's the learning environment. And so it makes our job really difficult because not only do you have to worry about how your faculty interacts with your students, but you have to worry about how your faculty interacts with everyone else.
Well, and to say it's not just faculty. So, like, we have an ethics where the students write a paragraph about ethics, and one of them, actually, they didn't submit anything for mistreatment to their med school, but they actually talked about how the nurse spoke about a patient. So again, that learning environment's everybody that they come in contact with. It's the patient, because we've had reports that the patient was belittling to them. We've had consultants. And again, these are all in environments, so they're all getting reported to me, or I'm hearing about them. But again, it wasn't anybody that was directly involved in it, except nursing. And some of our biggest comments that we've gotten is actually from more the nursing, more so than the faculty. So I actually meet yearly with all our nursing and show them reports that have come up issues where nursing have been noted. And if there's big issues, then it's even more often than that. So again, it's everybody in our environment that goes into the learning environment.
So, these are some of the elements that you need to think about: the learning space, the size of the group, the learning materials, what teaching methods you're doing, what's your assessment method. So, do the students feel like they're getting pimped? Students hate that teaching method. The learning space is actually kind of interesting for us. In one of our zones of the ED, there's not enough computers oftentimes for the student to sit in the doc box. Like, I don't know how you guys have it, but I hate that. Most of the teaching happens in the doc box, right? When we're taking presentations and we're going over the residents why we're ordering a D-dimer, and the student gets ostracized to the workstation that's like down the hall and they don't hear any of the teaching. I really worry about that. And I tell the students, grab a workstation on wheels and, try to get in this room if you can. A sense of belonging. You have to think about transportation. We have our students go to some inner city sites, and some of them take a bus there. And that's an issue, right? I mean, if they're getting out of a clinic at, let's say evening hours, these are things that you need to think about.
I'd say we have one site that's about 45 minutes away that we don't provide them housing, but we kind of work with the residency where, so again, if a student feels unsafe, they can stay at the site where our residents stay for after hours. We have had students ask if they can move into it. We say, no, that's not the purpose of it. They don't want to live there anyways. You can ask their residents in the back. But yeah, so it's, again, if they feel unsafe for whatever reason, snowstorm, I just don't do well at night, there is that safe spot where they can go and, spend the night at. So again, like you said, it kind of goes in with the learning environment as well.
So the ideal learning environment for a student would be welcoming, collegial, there's mutual respect, it's trusting, they feel safe that they can answer questions, it's engaging, it's team-oriented, it's supportive of learning. Obviously, these are all things that we really strive for. The things that you have to eradicate from your learning environment is not communicating expectations, a culture of fear if you're going to get a wrong question. Scut work. I struggle with this one a little bit. Every time I ask a student to go call a nursing home to get nursing home records, in the back of my mind I'm thinking, is the student going to perceive this as scut? I mean, it's patient care, right? But, to have them go up and get you a cup of coffee, that's a poor learning environment. Students are unable to express their views. They're disrespected as future colleagues. No sense of ability to respond, unjust evaluation, excessive workload. So the LCME, and Luan's going to talk about the LCME, so feel free to chime in. But when your site visit comes, for those of you that have a medical school, the way this works is you should really be doing annual reviews. The LCME is really big on continuous quality improvement. And so looking at your evaluations and making changes to your curriculum, that happens annually, and you're doing this continuous quality improvement, and then before your visit, you're going to do a self-study, which is essentially like preparing for the visit, and you're going to look at your institution, and then you'll pay someone to come in and do a mock visit, and there's actually some emergency physicians. Do you do that? Yeah, Paul Coe from SUNY Upstate, I know, is one of the folks that does that. So there are some emergency physicians that do these mock visits, and then you'll have your visit. And so the things that you want to start thinking about, I know somebody had mentioned, what do I need on my evaluation? Some of the questions we ask: did the student consistently demonstrate professional behavior, was reliable? I'm going to show you some of these questions. These are some questions that I use at my institution on the learning environment. The faculty, healthcare team, and other staff on this assignment created an environment that promoted appropriate professional values. The students were treated with respect. And we have drop-downs where if you answer that the student wasn't treated with respect, you have to kind of elaborate on that. Do you feel the supervision of you as a student was sufficient to promote a safe environment for you and your patients? So were you told to go do a chest tube on Mrs. Jones and not given any, direction? These are the questions that we use to address the learning environment. I'm happy to share this with you. We have a standardized evaluation of clinical instructor. This is a form that's used throughout our medical school. And we have the question on there: this teacher avoided ridicule and intimidation. This teacher treated me with respect. This teacher treated others with respect. Again, so the attending that berates the nurse but treats the student like gold, they're still not respectful of the learning environment.
I'm going to jump in just one thing.
Yeah.
And I think one of the challenges with the LCME is that everyone all of a sudden, especially if you have a site visit coming up, wants to be very responsive to this. And I really struggle with balancing the right number of questions for either your end of clerkship or your faculty evaluations, because there's so many different things, and these change over time. So they will morph. 3 years later, they're going to look potentially a little different. And how do you balance the number of questions that you ask of students? Because you want them to give you real and honest answers for that, and yet sometimes I feel like the students really suffer from survey fatigue when we survey them continuously at the end of every clerkship and evaluation. I mean, this is something I've really struggled with. What's the right number? And to me, if there's more than like 10 questions, I can't tolerate it. So think about that as you're designing that, but I think probably all of us have things that we're probably willing to share if you're struggling with that. And how many people are on like their their curriculum committees, like sit on their curriculum committees? Okay. So for the folks who have required rotations, are there ways for you to get involved? Is there a sort of a spot for you to participate in those, or do you have to be elected to those positions?
The answer is you have to be elected.
Okay, because those are good ways to get involved and really figure out sort of what's going on with these types of things.
Yeah, I think if I could echo that, if you have an opportunity to be on, for us it used to be called the Med 3-4 committee, and it was it's just opportunities to kind of look at these things, go over your evaluations. So yeah, just as I continue, the LCME Standard 3 mentions that you should have diversity, pipelines, programs, and partnerships. I think our specialty probably does this pretty well. For those of you that are on the CDEM listserv, we see a lot of visiting institutions for underrepresented groups in medicine, where they can get like a stipend to do a rotation there. This is our program. It's called the MedPath Program for diverse students or underrepresented in medicine groups. So it doesn't, I think there's no one best way to do this. You just need to make sure that you're doing this. As far as professionalism, you have to enforce appropriate professional behaviors in students, and you're responsible for the periodic evaluation of the learning environment. That's in the LCME standard. So just as Luan said, you can sample some of these things, but periodically you have to look at the learning environment. And just keep those things on record for when you have your site visit. So these are some actual reported cases. You're hearing a medical student present a case to the team of a male patient who's HIV positive. The resident then asks if the patient is gay and if he's a, quote, pitcher or a catcher. The student visibly, this was reported to our ombudsman. This is a real case. The student, visibly uncomfortable, says he doesn't know. Chiding and kidding then begins about guessing the answer to the question. So real case, reported by our students. How do you handle this? I don't know exactly how this panned out, but I mean, for me, we all have different styles, right? But I think this is an opportunity to educate the whole group on, I know there's different ideas about calling people out, and in medicine we don't like to call people out in front of other people, but this is clearly unprofessional, and everyone saw that. And, it might be an opportunity to say, as a medical school, we're required to behave in a certain way, and this is inappropriate, and we can lose our jobs if we behave this way. So I could see a resident with continued behavior like this getting fired. So real case from our institution. Effect of gender on clerkship experiences. You can't stereotype regarding roles. So you made a comment about OBGYN. And I was wondering if I did my OBGYN rotation at the same place you did, because I had kind of a bad experience. But people get stereotyped on different rotations based on their gender, right? So if you're a male student on OBGYN, you may be treated differently than a female student on OBGYN, vice versa, neurosurgery, or, you know, insert your specialty here. So we can't do that. We can't stereotype based on gender. So just know about these things. Romantic sexual relationships. So we hit this pretty hard with the residents, right? Because the residents and the students, they're kind of all together in the mix and things happen, right? So romantic or sexual relationships constitute a conflict of interest. I think we're getting better at this. How many people have to complete a CBL on this every year? A computer-based learning? Do you guys have to do? I have to do one every year on this. Maybe it's because of what a, no, I'm just kidding. But you know, if you're not teaching this, you need to be. So, you know, we have a computer-based learning that, you know, talks about this. Title IX says no person in the United States shall, on the basis of sex, be excluded from participation in, denied the benefits of, or subjected to discrimination. We're a large university medical school, so we deal with issues like this, but know that this exists and that we can't have sexual harassment as a part of the learning environment. These are other types of mistreatment, and sorry, our slides got a little jumbly in the thingy, but neglect is a type of mistreatment. So you mentioned your medical student who presents a patient and then goes off on their own. That's on the medical student, but it's also on us if the medical student's on shift with us and we ignore them the whole shift. And that happens. And so neglect is mistreatment. It could be reported. Microaggression, lack of civility. This happens a lot, and I really hate it. It's the, why are you going into emergency medicine? You're way too smart for that. Or why are you going into family practice? You're too bright. Don't do that. That has got to stop at all the institutions. Because, you know, I mentioned at the beginning, like I used to feel like some type of inner pride, like the more students went into emergency medicine. But really it's about having the students find the thing that gets them excited like this does for us, right? And so if somebody wants to do ortho, by all means, let them do ortho, but don't bash, you know, another specialty. And I know that that still happens, and it's a shame that it does. Different treatment of a student related to specialty interests. We got to be careful with this. This is very, I think, unconscious. But how do we react on shift when a student's going into EM? Like, you know, we're a little bit more engaged with that student, don't you think? So we have to be careful there. We need to make sure that every student gets our full attention. The AAMC graduate questionnaire has information on this. So you're going to get your information from the AAMC GQ, and you can see how you perform on these in relation to other medical schools. During sit-down rounds, the attending arrives a bit early. The resident is finishing up an urgent consult. The attending gives her Starbucks card to the medical student and asks him to get coffee for the team while she finishes up writing notes. So the attending's paying for the coffee. Is this appropriate? It's really not. I mean, even though you're paying for it, the student's being asked to go up to the coffee shop, and probably most students wouldn't mind this, but you know, if you're going to buy the coffee, just go up there and get it yourself, and that way you won't be perceived as that. But what if the student were asked to get an MRI disc of an urgent consult? You know, sometimes they can see that as scut work, but you need to make sure that they understand that they're participating as a member of the treatment team. And that's kind of what I try to tell them. And actually what I do is, if there's a stack of nursing home records, we all see this patient once a shift, I'll sometimes give it to the student and say, hey, do you mind going through this and writing a note on the pertinent hospital course that the patient had at the other place or whatever? And, you know, just letting them know that that's an important thing, so not everybody has to go through those things every time. Another actual case, a student on a colleague's team comes in for advice. She stumbled on a presentation the other day, and the attending said in front of the whole team, well, I suppose that's okay for a blonde. Today he said, after seeing a bookish patient, I bet you like nerdy guys. These are real reports. How do you approach this situation? So the other thing I'll mention is this. As a clerkship director, depending on where you work, you're responsible for addressing these. So the way we address these at my institution is when there's a report of intimidation, ridicule, a work hours violation, that goes to the clerkship director to meet with that attending, and then we report it back to the medical school on what the results of the meeting was. So in this case, you know, this is sexual harassment. The clerkship director would meet with that person and then have to, you know, kind of reply what the response was. So, you know, sometimes if it's the first, I mean, this is pretty egregious. Let's say it's not this egregious. If it's the first offense, it might be faculty development. But if an attending continues to violate the learning environment, they may be taken out of service. And this happened to us at our institution. We had a surgeon who had multiple learning environments, you know, threw a scalpel at somebody and yelled at somebody else. And now, and I don't even know if that person's in our institution anymore, but that person was not allowed to work with medical students anymore. So those are things that you need to know about. Yeah.
How do you collect this data?
So the students can report it on these evaluations, what we call the standardized evaluation of clinical instructor, or at our institution, you need to have a reporting mechanism. At our institution, we have an anonymous ombudsman kind of website, right, Jim? You guys can...
Yeah, it's online. You can do it totally anonymously and just type in whatever you want. If you want to provide more information, that they can help follow up the situation by providing, I don't know, something that would be pertinent to the shifts that you were on, or if you want to provide your name and waive the anonymity of it, you can feel free to do that too.
So that's where I think these came from, was that anonymous reporting thing. And the only issue with the anonymous reporting thing is then you don't know who put it in and who's it about. It's a lot easier to follow up with. So this is one thing I struggled with. Am I going long? Or, I struggled with, let's say there's an episode of intimidation or ridicule, and the student puts it on their evaluation of the clinical instructor. We'll reach out to that student and say, hey, we'd really like to follow up on this. Would you care to elaborate? And the student would be like, I thought this was anonymous. And you know, we'll have to advise them that these evaluations are confidential, but they're not anonymous. Meaning, if we have to track them back, we can. I mean, if you were sexually harassed, we need to know that, right? We have to follow up with that attending. So this is part of the reason I'm presenting this is a tricky, I think in medical education, this is a tricky area. Yeah.
Yeah, I had questions about this because I had one of these come up, and the things that I had trouble with were, number one, I took the person off the list of getting medical students, but the reaction is like, yes, I don't have to have medical students anymore. And I thought, well, other people might think, I don't want medical students.
Yeah.
You know, behave badly just to get out of it. And then also, it would be noticeable if one person never had medical students and other people always did. And I wondered if they might then know that that person is, if that's not, I mean, that's the last concern because of their problem. But
Well, one thing is so for us, I mean, ours gets reported up if any of those complaints to our chair. They actually also get onto the promotion packet. So this is someone who's looking for potential promotion. Any of those sort of things that's identified to them. Okay. Yeah. So yeah, so in a community site where they may not be looking for promotion, it is a little tougher to kind of get at those. I think a lot of like the less supported sites are kind of tough for some of these. So we have, similar to what Nick was saying, we have an online reporting system where the students can also embargo the report until like even graduation or even after they graduate. And again, talking about harder to follow up, even those are, like I said, even more difficult. There are some that they can release right away. There are some that they can do as anonymous, or ones that say, so they have their name identified. So like Nick said, if there are very egregious things that can get tied to them, but they all get reported to the associate dean of the medical school. So he's the only one that has access to their actual name if there's issues. So I may hear about, hey, there's an issue in your department, but not have any more specifics than that, may not even know which faculty was involved. And so we do a learning environment talk at the beginning of each year, talking about some of these things, what issues. So we don't hide when there's issues. So kind of like Nick was reporting, these sort of things I'll actually bring right to our faculty and right to our residents and to our other sites and say, hey, this is what we've heard, this is where issues have come up. One of our sites, which was always like the one that got reported, we don't hear issues from that anymore because, again, it's just bringing to light some of these things that people are saying. Or students are even overhearing. So, again, like Nick's saying, you may not be anything directly on the student, but if you're overhearing a nurse saying something about a patient, then that's what our last one was. Like I said, this nurse saying something about the patient. Nothing to the student themselves, but, again, it's that learning environment. So, again, we are very transparent with our faculty, with our nursing, with that.
I was just going to say, when you choose so when I've had issues like this, right. When I've had issues like this before, one of my allies has been the chairman, actually, because clearly for a quasi-community site, not being able to be promoted is not a big deal. I mean, you've got people that are just working and whatever, but if they understand that their employment is tied to it, I mean, this is granted, assuming you have a chairman that's got your back, but, if they understand that language, right? So that's something, you don't have to kind of fight that fight alone, I think.
And at our school, so everybody, that is an LCME guideline, everybody has to have some sort of pathway as to how they're going to deal with mistreatment. And the clarity of the pathway will be one of the things that's really evaluated when the LCME comes. But making sure, so we have the hot button sort of site on both medical education and student affairs. We actually ask at the end of every clerkship, did you have any instances of mistreatment, so that we can gather them. We don't report them out after every clerkship because the fear of sort of retribution from the students, especially if their grades aren't in yet. But so we cluster them into like a quarterly basis, and we send them all to the chairs because honestly, frequently the clerkship director is relatively junior compared to some of the faculty who are doing these things, and so you really have to have the chair on board. And we actually institutionally we make it largely the chair's responsibility to deal with these issues. And I think as challenging as they are, we have actually had some really good outcomes. I mean, some cases of unconscious bias actually relative to OBGYN and the staff and saying inappropriate things about patients, and it was really an unconscious bias issue. So they were able to bring training in and actually train the staff. And so there are opportunities to really improve the learning environment through these, while it is painful to initially receive them as the clerkship director.
Yeah, I agree. The other interesting piece, and there was a paper, and I want to say it came out of Michigan, is the comparing the learning environment reports at your institution to what you get on the GQ questionnaire. They don't always line up. So students are reporting these on the AAMC graduate questionnaire, but not reporting them internally. And I don't know what to do with that. I think this was a, hey, this is an issue, let's discuss kind of paper, not a, here's a solution. But, so just know that. 3.6 for the LCME standard talks about student mistreatment. I think we hit that pretty hard. Incidents, again, embarrassment, humiliation, aggressive questioning. We got to be real careful with how, quote unquote pimping, as I don't want to say older, I guess mid-career, I don't know what I am, but you know, we were all asked questions on rounds in front of everybody, and there were a lot of times you didn't know the answer. You got to be careful with how you do that nowadays, because students can perceive that as belittling or pimping, those kinds of things. And we hit a sexual harassment and all these things pretty hard.
So I'm going to push back on that one because I think this is a real challenge for me. I think we have to norm the environment that it's okay not to know the answer, but it's not okay just to not ask students questions. Because I think we struggle with, well, if students, and I do think some students perceive being asked questions that they don't know the answer to as being belittling. And so I think we have work to do on both sides. It isn't fair to sort of grill people until you don't get it right or until people are visibly upset. But I mean, if you get the responsibility as a student to take care of patients and be in closed doors with sharp objects with them and whatnot along the way, you have a responsibility to be able to answer questions about them. So I think part of our jobs are actually educating the students that it's okay not to know the right answer, because we don't want it all of a sudden for faculty to stop asking questions.
I would say that's actually what happened in our surgery rotation. The faculty just stopped asking questions. So then they actually started getting mistreatment reports about not asking questions, about not involving. So I think it kind of goes back to just the overall learning environment. I mean, if it's felt to be a supportive learning environment, and so I actually, during my orientation, say, you need to come up with your differential, you need to come up with an assessment plan, you're not going to be right. And I'll say, if you're going to be right all the time, you shouldn't be here. So again, you're setting it up saying that you're going to be wrong some of these times, and that is right. That's what you're supposed to be. That's why you're a student. That's why you're a trainee.
Well, and I think what you said is really important. It's a matter of how you frame it to the student. Oh, sorry.
All right.
It's a matter of how you frame what you're doing to the student so that they understand. Like, you know, we're all in the room. We all probably at some point we got pimped just because they wanted, you know, whoever it was, they wanted to show that they knew more than us. Well, yes, you're an attending physician. You know more than the third-year medical student. Congratulations. But so what I've done is like, okay, I'll be asking you a series of questions. You may not know the answer to that. That's fine, but it gives me an opportunity to know where we need to start more discussion, more teaching, so that you get more benefit of that. I'm not explaining things to you that you already know. And, I'm just trying to get to where you're at so that so I can meet you and we can go forward from there.
Yeah, so Luan, I totally agree. I don't think the answer here is not talking to the students. We need to do faculty development to our faculty to let them know what the best way to ask these questions are. Again, you can't mistreat based on identity group. Again, this is just another kind of a sexual harassment complaint. We hit those pretty hard. So strategies for improvement, again, learners must be welcomed and included. You have to have civility for all learners, enhanced training for teachers and residents, resilience training for learners, faculty involvement. So you had asked a question about your community sites. I really struggle with that. So we have 9 sites, and we have community physicians there, and we ask them to teach, and in return they get nothing, really. I mean, they get access to our library, they get access to our CME. Yeah, big whoop. Guess what I get asked? You get asked the same thing. Can I get football tickets? I get asked that all the time. And I say, yeah, join Buckeye Club, and you can buy yourself some football tickets. But engaging those community preceptors, we actually allow them to apply to be auxiliary faculty. I mean, these are small things. They're not great, but they're better than nothing. The other thing I would just say, too, is we have a site director at each community site. And that person knows who the good teachers are. And actually, not all the emergency physicians at that site typically work with students. There's some that, at some of our sites, there's some that actually opt out. And maybe there's some that are opted out. But, so that's something, we have to think about. But that doesn't work for all places. So there's some references on that. So difficult topic. something that takes, I think, a lot of experience to really get good at. I know I'm not an expert at this, and that's why I wanted to kind of sift through some of these issues. But if you guys, again, if you have questions about our evaluations and things, happy to share.
I'll say that the other time that we at our institution have the biggest mistreatment is in July. So whenever people are changing from intern to senior and it's those periods of greatest stress, we have the absolute most, and we have new medical students who don't know what the expectations are. Part of this is why we actually rolled our curriculum back so that we didn't have all the new people in the space simultaneously, hoping that that will help with some of those issues.
All right, so we're gonna try to get people up, moving around a little bit, talk a little about bedside teaching. And again, obviously, we all know it's not how to shadow a doctor. So again, how do we actually make this more interactive? So I'm just gonna kind of touch on SNAPs, SPIT, 1-minute preceptor, and teaching scripts. And then we're gonna kind of get up, go to each of the same sort of things, split into the different groups, and talk about what experience you might have with it. You know, if you have any experience with it, if not, how might you be able to utilize some of this? So again, so what is it? So SNAPs, summarize briefly the history and findings, narrow the differential to 2 or 3 relevant possibilities, analyze the differential, comparing and contrasting possibilities, probe the preceptor by asking questions about uncertainties, plan management for the patient's medical issues, and select a case-related issue for self-directed learning. So that's SNAPs. SPIT, so you're looking at serious, probable, interesting, and treatable. So again, what are the, serious, the can't miss diagnoses, being the most probable diagnosis for the P, interesting diagnoses, and then the treatable diagnoses. 1-minute preceptor, so it's 5 steps. So brief H&P, again, they're going to provide the probable diagnosis, why did you decide on that diagnosis, what are teaching pearls, and then so you may have your own kind of teaching pearls about that topic, providing positive feedback to the individual, and then also doing some correction for the individual. And then teaching scripts. So these are pre-planned teaching points. So again, what are the goals for instruction? An example would be is we have one of the faculty on our PZD who, bronchiolitis, especially during that season, she's got her scripts and she knows these are the teaching points I want to make sure the students get by the end of it. So again, what are the key teaching points? Is there any evidence-based sources that you're providing that? And then again, what are the things would be acquired knowledge of the learners and common difficulties? So again, thinking again of that PEDS-EM, a lot of our students that come through haven't had PEDS in a year. So again, what are those key areas where their learners have errors? The one with the teaching scripts is we actually have some of our faculty that use something very similar with our residents, except for obviously it's just making things a little more difficult, a little different teaching key points.
I do some of my shifts at one of our inner city community sites where we have some nurse practitioners and some residents, but we're still responsible. We probably see about half the patients on our own. And that last slide reminded me of when I work with a student there, a lot of the times I'll go in and see the patient first. And if it's interesting, then I'll send the student in. And I don't tell them that I've already been in the room. A lot of times they'll find out. They'll talk to the patient and be like, who was the other guy that was in here? But they have a white coat on, so they think they're the doctor and I'm just the other guy. But I don't send, because we had faculty there that were like, the students are slowing us down. It's taking so long with the students. And I told them, I said, the students don't need to know that you were already in the room. And then you have an idea. When they present, you know exactly what the presentation should be. Somebody's here and they're yellow and they have liver failure and here's my teaching points. I've actually found that to be really helpful, and that slide reminded me of that. And so at that particular ER, we've tried to do some faculty development on if you're real busy and you feel like the student's in the room for 30 minutes and taking too long, that's a good way to go about it.
And I say there's actually one of our faculty members that does that even with the residents, kind of sees them first. And they've actually caught some patients that were mistriaged. So they've had patients kind of in our non-acute area that they're rushing up to our recess bays. And it's not so much that the patient really changed. It was just that in the screening questions by the nurses, it just didn't get to that one point. So there is, like I said, some of that I kind of going and seeing beforehand. So again, what we like to do is kind of, again, have everybody kind of get up, split into 4 groups again, and we'll go around to the different stations.